Before I start the introduction, let me just tell you, for all those of you who are out there who are board certified with the American Board of Pediatrics, we are doing an experiment this year to see how much people value this. But we're going to give MOC credit, part 2, for all 3rd, 4th, and 5th Tuesday of the month grand rounds. The Tuesday of the month is, a surgery, and so they get surgery credit, but we can't, it's too complicated to get MOC credit for ABP. And second Tuesday of the month grand rounds are valley-wise, so we don't have any control over that. But for those of you who are attendings who want part 2 MOC credit for every grand rounds that you attend, you get 1 point for every hour that you attend. All you have to do is go through on a browser, go to your Cloud CME portal, and then go to tests. And then you take a 1-question test, and you can have more than one chance to get it right. And once you get it right, then you get that MOC point. And at the end of 2025, we'll reevaluate if it's kind of worth it to, if people are, taking these quizzes and getting their points and like it, then we'll continue. And if not, we may not. So anyway, this morning, it's my pleasure to introduce our speaker, who's one of our own, Dr. Karen Yeager. Is one of our pediatric ED faculty here. She's originally from Houston, Texas. And after completing medical school at the University of North Texas in Fort Worth, she moved to Phoenix to complete her residency and fellowship training at Phoenix Children's. Then after fellowship, she completed an MS degree and became board certified in clinical informatics in June of 2022. Dr. Yeager is passionate about bedside medical education and loves teaching residents and fellows, as well as leveraging data analytics solutions to improve patient care and workflows. As such, she joined the fellowship leadership in April of 2023 as an associate program director and the clinical informatics team in October of 2023. Outside of work, Dr. Yeager loves to bake, travel, and do it-your-own crafts. And she spends most of her time with her husband, daughter, and her 2 labradoodles. Okay. So without anything further, here's Dr. Yeager to talk to us about dealing with pediatric emergencies in the outpatient arena.
Okay.
Use that, or there is a clicker.
Oh, awesome. Thank you so much.
And then at the end, I'm going to come up when it's time for questions. I will come up and do a little thing here so I don't distract you. That will allow the ceiling mic.
Okay, great. All right. Awesome. Thank you. Thanks everybody for joining, and for those of you in person and online. Basically, Dr. Hartley already went over all of this, but this is a little bit about me, and I'm really excited to be here to talk to you guys about in-office emergencies. And just a spoiler alert, this is not going to be like sophisticated management for when emergencies happen in clinic settings. It's going to be mainly call for help, get them to a higher level of care. But what can you do in the meantime while you're waiting for emergency response to optimize patient outcomes, what you can do in the space and resources that you have, and how to reduce the stress for your team, because we all know that these events, while rare, can be really stressful for your staff. So by the end of this, we should be able to prioritize and implement stabilizing care using commonly available formulary medications and supplies while awaiting emergency medical services. And that includes optimizing your location internal to your clinic and also within the physical location where you're located in the valley, your team and equipment. We'll evaluate clinic vulnerabilities and discuss possible strategies to implement improvements, such as identifying and labeling your resources, having a plan, and practice. And I'll give you some resources on how to do that. And then at the end, we'll finish off with some cases describing common inter-office emergencies encountered by a general pediatrician. This is not an exhaustive list, and we definitely, hopefully, will have time for questions at the end. So before we get into cases or anything, let's talk about literature and best practices. So what type of emergencies do clinicians typically encounter in the outpatient setting? There's several that are common, and there's some and few that are rare and very stress-inducing and scary. So common things, of course, this time in particular, we see a lot of respiratory emergencies. Your asthmatic and acute respiratory distress, the croup patient with stridor at rest, or bronchiolitic who may be working hard or hypoxic. Seizures are not uncommon. Syncope, with especially associated with vaccine administration or blood draws. dehydration, secondary to gastroenteritis or other things, and that can be with or without hypoxia or hypoglycemia. Excuse me. And then infection and fever is a very common pediatric complaint. I think one of the harder pieces to tease out is when do you get concerned for something more serious, such as sepsis or serious bacterial infection. On the rare end of things, we see DKA or new onset diabetic who can come in looking very sick. A cardiac emergency is everyone's big fear and how to address that, or an arrest event. Increasing nationally as well as locally is acute mental health emergencies such as a suicidal patient or an agitated patient, and this is increasing for everyone. Suspected child abuse, anaphylaxis, or an ingestion or altered patient. How often do people tend to encounter these types of emergencies? One study found that estimated incidence range in urban settings is anywhere from once a week to twice a month. So, and this is for clinicians that are referring patients to emergency services, either directly to the ED or by ambulance. Another study in 2015, this surveyed hundreds of outpatient primary care practices and had about a 46% response rate, and 75% referred a patient to the emergency department or hospital at least once a month. Current pediatric advanced life support, so PAL certification, was maintained by 21% of staff, and 42% had BLS certification. And this figure shows the type of emergencies that were commonly encountered by frequency in the respondent surveys. So you can see respiratory and asthma was very high, as well as seizure or infection, whereas on the lower end is a dysrhythmia or cardiac arrest event. So how do you prepare your office for a potential emergency? So basically the literature has shown that this is going to happen. This is likely going to happen with some regularity. And how can you prepare yourself and your staff to best respond? The first step in the literature is often recommended to be an office self-assessment, and we'll go through what that can look like. But that is basically to see, what type of emergencies, and this visual on the right is useful for thinking about this, but what type of emergencies are you expecting or have you seen in your practice setting? Assessing what kind of supplies and medications you have in your clinic space to respond to those emergencies. Do you have gaps there that you need to address? Performing scavenger hunts, like how easy is it in an emergency setting to go and get these things? Are you going to 3 different locations within your office, or is it all right there, packaged, ready to go? Engaging in mock scenarios, such as simulations or case practices, and then reviewing and debriefing. So this kind of assessment helps to form what ends up becoming an emergency response plan. And that can be, you can call it a policy or an SOP, but this plan is a written statement that outlines what your practice is going to do to respond to a clinic emergency. It helps you optimize what equipment and medications you have available and have stocked, optimize your location, both in the office, as I mentioned, as well as for transport, personnel preparedness, and that the simulation and practice events, as well as debriefings, help a lot with that. And then what do you do post-event? So a little bit more about the office self-assessment. This is, by any other term, it's a needs assessment. You're basically looking at what kind of emergencies are you expecting to encounter in your practice setting, and how do you prepare for that? So things that'll affect this will be your clinic location, whether you're urban or rural, your patient demographics. That will definitely determine what types of disease processes and emergencies that you're expected to see. And then the proximity and accessibility to emergency services in a higher pediatric center is definitely key to how you're going to optimize your space and your materials. If you're expecting a 30-40 minute response time for EMS, then that is definitely going to change what you might want to have available compared to if you have a 5-minute, 10-minute EMS response time. The AAP actually has some resources for self-assessment, and I listed some of these questions here for you so that you don't have to go looking for this, but it's also in my references. And it's, a lot of the things we went over, like what kind of emergencies might occur, how is the staff trained to respond to emergencies, and that includes both clinical staff and non-clinical staff. We know that the front office staff and non-clinical staff are a big part of helping the day-to-day activities of a clinic, but they also have a role in when emergencies happen. How can they facilitate getting EMS to your patient and things like that? What equipment and supplies do you have? How do you access the emergency response system? Like, do you call 911? Is there a different line that you use? And what's the response time? And how do you maintain staff readiness? That's a big part of kind of once you do this initial work of what's the self-assessment, where are the gaps, what's the plan, and then maintaining that becomes an ongoing process through the life of your practice. All right, so let's talk a little bit more about the emergency response plan. As I mentioned earlier, we recommend that this is a written document that's maintained by the office staff and reviewed regularly. That'll include like medications, equipment, and your plan of action. Because if it's just something that's written once and then never looked at again, it's not going to be useful as you have staff turnover, new providers, new emergencies pop up, things like that. All right, so equipment and formulary. Now this can be a little bit tricky. I have a list of recommended essential equipment and also some things that are strongly suggested that I think comes with a big heavy caveat. So I think some things that are very key and important for success include an oxygen delivery system with like non-rebreather as well as a bag valve mask. Because of course, if a patient has no ventilatory effort, then you're going to want to be able to bag them. And that includes different mask sizes for pediatrics, some sort of suction device, which I'll talk more about later, an AED, an automatic one, a nebulizer device, glucometer to check glucose for an acutely altered or dehydrated patient, an EKG, and a backboard or CPR board. Other things that are strongly suggested, and I have an asterisk here because this comes from the 2007 AAP policy on emergency preparedness for office settings. This was published by the section on emergency medicine. So many of the authors for this were emergency providers who have a high degree of comfort with these listed materials. And also it's a document that was originally created in 2007. So I will just say there are things on there like activated charcoal, which is something that has really gone out of favor, just even in emergency settings. So is no longer routinely recommended. Things like C-collars, oral airways, IV access materials, McGill forceps, are all of these really valuable? Another one that's listed in the strongly recommended section is IO kits. If you're in a rural setting where you're expected to have a very delayed EMS response time, and you feel that your staff is seeing emergencies with the frequency that justifies having these materials on hand, and you can maintain the skills of using them and the stock and all of those things, then I think, yeah, there's a lot of utility here and it's great. If you think that this is going to be something that's going to gather dust, is not going to be used, and then it's something that you have there that everyone is going to freak out about and feel like they need to use when you have a patient, then you're probably going to do more harm than good by having that. So that's my caveat to that. Do what makes sense for your practice setting. If you're right across from a fire station, you probably can maintain C-spine precautions manually without needing a C-collar, things like that. You probably don't need to have IV materials if nobody in your staff has done an IV in 10 years. So things like that. And there's a full list in the AAP policy statement, which I'll link. But again, I think a grain of salt, like common sense, goes a long way with that. In terms of formulary, most of these things, so this list is all on our PCP, the Phoenix Children's Pediatrics formulary. And I think very useful both in office settings just for non-emergent cases as well as emergency cases. So albuterol and epinephrine auto-injector, both in the 0.15 and the 0.3 milligram dose. racemic epinephrine, oral and IM corticosteroids such as dexamethasone, oral glucose, IM glucagon, ceftriaxone, which usually in the clinic space is given IM as well, diphenhydramine, ondansetron, and naloxone. One caveat about naloxone for our PCP group, this is only currently stocked at one of the locations in Cottonwood. I think if you are in a practice area that sees a lot of drugs of abuse, or you have a patient demographic that is encountering this frequently, stocking intranasal naloxone would be a very wise thing, as we're continuing to see increases in this throughout the country. So tips for success here. All of these meds and equipment need to be stored in a place that makes sense, that's labeled well with bold colors, clear writing, and ID'd for ease of access. Your policy and plan should reflect where this is all going to be, how you're going to train your staff to use it, how you're going to maintain stock when things are used, how you're going to check expiration dates, all of those things. Now a word on location. So when I say location, I mean not only the physical setup inside your clinic space, but also where your clinic is located within the city. So the patient room setup, there is a ideal way to do this and a not ideal way to do this. So this figure shows like a riskier setup where the provider is in the farthest location from the door with the patient in between. And that can be difficult, not only if you have like an incapacitated patient that you now have to like step over somehow to get to the door and ask for help, or in an acutely agitated or aggressive patient, this can also be a danger for the provider. But in our population, where we're seeing more just patients that need assistance, what's the easiest way for you to exit the room and get help? There's a setup where the patient is farther from the door, but you are closer to the door for that. And then in case of emergencies, do you move the patient or you do keep them in the room? I think there are arguments for both, and it depends on multiple factors. So you want to optimize the patient positioning for access to your materials. Like if you have oxygen in one location and then that's not a very mobile location, then obviously if you have a hypoxic patient, you're going to need to move them. Is that feasible in a 2-month-old bronchiolitic? Sure. Is that a lot harder when you have a 100-kilo asthmatic? So those are things to consider, like where are the things that you need to treat the patient? Would that require moving the patient, or can all of that be brought to where the patient is? And then that has to also be brought back. So there's an argument for a treatment room if you can do that, but not all clinic spaces can do that. So there's definitely ways to optimize, like having, like this is your respiratory bucket or box, this is your seizure or altered mental status box, and things like that, so that you can move to where the patient is. And that also emphasizes the need for clear signage for medications, equipment, and any visual reminders. We are big on this in the ER because when things are going down and everyone is stressed and this is an unfamiliar or infrequent event, it's very easy to forget the things that without that stress that everybody knows. So visual reminders of what your emergency action plan is, how to get a hold of EMS, what your staff needs to do, reminders for each kind of emergency. These can be really helpful, and that can be hung on the wall in a treatment room, or it can be in a binder for your emergency action plan. There are definitely multiple ways to do this. And then external clinic factors. Is your office located in an office tower that requires like a lobby security check-in and all of these, or you have to like go through multiple elevators or stairs to get to your clinic? Or is it located in a corner tucked away in a strip mall, so it's difficult to find? These are things to kind of game out with your staff. How will EMS access your facility? And designating, if it's a difficult to reach place, it's important to designate a staff member, preferably a non-clinical staff who's not going to be bedside taking care of the patient, to meet EMS and direct them to the patient. And then a big part of responding, the human factor, is one of the biggest things that can be difficult to control, but also very valuable in the moment. So personnel preparedness. You want to identify who your team members are going to be. Of course, this is going to include a clinical provider, physician, or APP, an MA or a nurse. Not all clinics have a nurse like 24 like during full service hours. Front office staff, as I mentioned, they definitely have a role, even if it's not bedside care. And then in your construction of your emergency action plan, you want to determine how your staff and shift variations will affect your plan and your response. Do you have one staff Monday, Wednesday, Friday that have 15 years of experience and they don't bat an eyelash with this stuff, but Tuesday and Thursday you have brand new staff that may be a little bit more hesitant and need additional training? You have after hours clinic that is going to provide different services. So shift variations can definitely affect who the team members are and how they're trained and how they respond. So, and then planning a process for notifying emergency services in response. So different training modalities. BLS is every 2 years certification. Mock codes and simulations. I'll give you some resources at the end for how to access some of these that are open source. But then also each location is going to have to determine, depending on what your staff makeup is, what your comfort level is, the frequency of cases you're seeing is going to determine how often you do training exercises or review your emergency action plan. In the winter, if you're transferring a kid a week to the ER for various emergency respiratory cases, then you probably don't need to do mock simulations of those cases additionally. But maybe that's a good time to go through, like, what would we do if a patient was seizing, because we're not seeing that as often. So things like that. And then arranging transfer. What information do you provide local EMS providers and the accepting ED? And do they go by BLS or ALS? So this is one that this comes up, this question of BLS versus ALS comes up often for our providers, as we're both receiving patients from other facilities and transferring patients out. It's something that's tested on our emergency boards, and we have to review it every year. So if you don't know the difference, that's totally fine. But there's 2 tiers of medical care in the pre-hospital setting, roughly broken down as basic life support and advanced life support. The basic life support, like the long and short of it, is that they can do non-invasive care, do CPR, and use automatic defibrillators. So they can do like oral airways, they can bag a patient externally, but they cannot put in an advanced airway or an LMA or things like that. They're not going to be putting in IVs. So any patient that needs any emergent infusion treatment, medications, things like that, advanced airway support, positive pressure ventilation, all of that is going to go through advanced life support. But if you just need a patient monitored and transported to another location, BLS is probably a good way. All right, so now you know who you want to call and how you're going to call. What do you tell them when you call? Who's making the call is important. If your front office staff is the one making the 911 call, that may limit the amount of clinical information that they're able to provide. So if you're able to start treatment or call 911 while somebody else starts treatment, that would be optimal, so that the 911 receiver is getting clinical information conveyed. At minimum, I think it's good to present the patient's name, age, and sex, what their chief complaint is, vital signs, any interventions you've provided them in your clinic, and any pertinent physical exam findings. Additional to that is any special instructions, as I mentioned, for getting to your space. And you can say something as simple as, my front office staff will meet you in the lobby and escort you up to the 5th floor where our clinic is. And then as you're working on your simulations and your preparedness, there's some resources here to provide that makes it easier. I mean, you absolutely could use scenarios like that's, I think, that very effective. If you just had a patient last week that you had to send to the ER for croup or for anaphylaxis, going through that case that's fresh in everybody's mind is extremely effective. But I also recognize that it's difficult to kind of pull these things out of thin air and have a formal resource to go through a scenario, test it, what are the learning points, things like that. This QR code at the provides a link to MedEd portal that has simulation cases that are in the office setting for asthma, anaphylaxis, and seizure. It also has downloadable appendices that has PowerPoint slides. It has like Word document checklists, a brief pre and post test, and a debrief tool. So this is really helpful. This gives you everything you need to run the simulation case in your clinic setting and also do the teaching associated with it. So I think that's great. And there are other, MedEd Portal has tons of simulation cases that are available. I will say, having gone through these resources, that some of them tend to read a little like more advanced emergency support than you might be willing to provide. So just go through the scenario and the teaching points before presenting it to your staff, and just see what are the things that are reasonable for you to do in the clinic and focus on those things. It's good to mention these are the other parts of the care that the patient will receive either by EMS or by their higher level of care, but don't feel obligated that just because it's listed on there, similar to that AAP policy, just because it's listed there doesn't mean you have to do it, or that if you don't do it, you're somehow failing your patient or not providing the best care. Doing what you can do well is more important than trying to do everything and not doing it well. And then, of course, BLS courses through the American Heart Association. We no longer do sponsored courses at PCH right now, but we have in the past, and we may hopefully again in the future. An additional external resources I want to mention, one big resource that I think that many people in the community utilize well, but I think could be utilized even more, is our connected care. So when anyone is transferring a patient to Phoenix Children's Emergency Department, they can call this number that I've listed here and connect to, it goes to a phone tree that staffed by a clinical nurse, and they can take all the information for the patient and also accept the patient on our behalf if it's simple things or routine things. But if there's ever a situation where you're like, oh, I don't know if I need to send them to the emergency department, should they go to urgent care? Should I just do watchful waiting? Am I doing the right thing while I'm waiting for EMS to come? Any of those types of things, we're more than happy to talk to you. And the nurses at Connected Care can connect you with a PEM fellow or an attending to talk about. And we do this every day, giving different community ERs and practices advice about next steps in management and referral and escalation of care. The QR code on the top is the policy that I mentioned from 2007. This was reaffirmed twice, and most recently in 2018. So this is the most up-to-date document that the AP has on this topic. But as I mentioned, take it with a grain of salt. This other one, I don't know if it'll let me actually go to it, but this is from the Arizona Department of Health, and this is actually, I just wanted to show you, this is their triage, treatment, and transport guidelines. This is an EMS document. So don't feel like this is stuff that you have to do. Like we mentioned, this is for EMS, like EMT basics, but also ALS. So some of this is going to definitely be out of scope. But if you're looking for like, hey, I just need some like quick visual reminders, here's a printout for a pediatric assessment triangle that you can literally just print out and put in your emergency response plan, or hang on your wall in your treatment room, or things like that. It goes back to the table of contents, and it has algorithms, like PEDS only algorithms, including group, like what can you do, like what's universal care, what are some steps that you can take, like suctioning, monitoring pulse ox. And again, like if you're sitting in your office reading about a case about Stridor, you know all of these things. But when a patient is looking like they are in severe respiratory distress in front of you, then sometimes the obvious things can slip through your mind, and that is very, very natural. So sometimes it's good to have like, what's the dose of racemic epi that I should be giving? You know, these sort of things, it's nice to have as a printout, and you don't have to reinvent the wheel on some of the stuff. So just wanted to make that available to you. All right, get back on the slide. All righty, so those are available for you. So now we're going to shift gears a little bit before we get into cases. You had an emergency in your office, you survived, the patient survived, more importantly, and got to a higher level of care. But now what? Everyone is like traumatized and frazzled. So what do you do? And that's when debriefs come in and can be really valuable. So there's different ways of doing this. In the literature, we talk about hot debriefs or cold debriefs, which both have value but are different. And it's a great way to provide support for your staff and also continue the process of improvement, learning from what's happened and applying it to future cases. So a hot debrief is typically used, it's in the moment, right after case is done, everyone's gone, things have like quieted down. And it's with the people that are involved. It's typically used for sensitive cases in our world, in the emergency room, unexpected outcomes, an unexpected patient death or code. If there's significant staff distress, sometimes like this can be really valuable for the staff that are there to just go through what just happened. But you can also, if things are really busy in the clinic, you've got to move on. Everything went relatively like the way you expected, or that didn't, but you don't have time to get into everything. Cold debrief is really valuable. And that's where you do more of your like you dissect the cases, could be days or weeks or even months later, but you go through everything that happened. Not all of the people that were involved in the event may be present, but typically there's staff leadership that are there. And this is where you go into like what the plan of process improvement will be. Some important questions to ask for your review and how to improve is, did things happen the way that you planned? Did what you had outlined in your emergency response plan actually happen? And if not, why not? Where are the gaps? What would you do next time? If you had a similar case in the next week, how would you improve your practice? Does your emergency plan need to be modified based on what you found? And then disseminating the findings to the group. It's important to do that so that the staff know where they can improve their practice and what they can do better next time, but also to have an opportunity to practice it, especially if that practice comes pretty soon after the event. That can be really helpful. You don't have to invent tools for debriefing. They already exist. Here are a couple that are listed for you. The acronyms are STOP or Take Stock. I really like the STOP one. This is something that I use in my own cases if I have a code event or a resuscitation that I want to talk to my team about. And it is very, very simple. Once you've identified that this is a case that you want to do a hot debrief on in the moment, you can take 5 minutes or less to summarize the case, talk about things that went well, opportunities on how to improve, and points of action and responsibilities. And you can talk about like this. Okay, so nurse, like that, like I noticed that the patient was hypoxic and we didn't kind of get oxygen on them until 10 minutes into the case. Like, how can we optimize that or make it better? And go from there. This can also be blown up and printed out, placed in your treatment room to be a reminder for as a visual reminder, like, hey, I need to do this debrief, because you can forget in the heat of the moment yourself when you're thinking about everything that just happened. And it's also a good reminder of like what the pieces are. All right, so now we're gonna shift gears and go into common office emergencies. We're doing pretty good on time. I have 4 cases, and if we don't get to all of them, that's okay. Or if people in the audience have questions about cases they've experienced afterwards, and hopefully we can talk about that as well. All right, so this is the QR code for the Slido, and I think how do I go to the, here we go. Well, actually, before I go to that, this is the case. So 2-month-old male presents for their well child check. Parent notes 2 to 3 days of progressive increased vertical breathing and copious nasal oral secretion. Now they have poor feeding. They've had 1 wet diaper in the last 24 hours and increased fatigue. This doesn't sound familiar to anybody in the room at this time of year, I'm sure. So their temperature, they're afebrile. Their respirators are 65 with a SAT of 86% on room air. Their heart rate is 190 and their BP is okay. This is what they look like. First, you're going to get an ad about Cox. All right. Oh, let me see. Bye. Oh, do I go here? What? Little snafu.
Okay. Maybe we can. We'll go share. We are sharing. That's. Okay, here comes the chief. Okay.
Oh, she'll know. Sorry, technical.
Okay.
It's not critical to the case, but so if it doesn't work, it's okay. Oh.
Okay, there we go.
It's a-
I don't know if
Curious,
it'll show
George,
up on
just so-
Zoom, but
Oh, yeah. Wrong. Let me see if I can go. I lost my. Want to play that. Lost it. That's okay. Now I can't even see. Don't worry, guys. This is the only video, so. If it doesn't- Okay. Oh, great. Perfect. Yeah, there you go. So that's what the patient looks like in your clinic minus. All right, so. Go back to, there we go. Yay, success. All right, your next course of action, or your first course of action would be what? A, suction and place on a non-rebreather oxygen mask. B, call 911 and arrange transport to the ED. C, proceed with a 2-month well child check. Or D, swab for RSV and flu. All right. Okay, so this is perfect. I like that there was some people split between suctioning and placing on an oxygen mask and calling 911 and arranging transport. Ideally, both of these things would happen at the same time, right? And that is often like when we're doing board review or going through cases, that's like the number one frustration is a lot of the answer choices is like, yes, to A through D. You know? So I appreciate that nobody wanted to continue with the 2-month well child check or to swab for RSV or flu, because that's not going to do anything for the management of the patient. So let's talk about calling 911 and suction. So basically both of these are right. You know, I think 6 of one, half a dozen of the other, right? This is a patient who has obvious signs of respiratory failure. Clinical signs for this include tachypnea, their accessory muscle use. So I gave an example of the head bobbing, which can be a late finding, but retractions, nasal flaring, stridor at rest, hypoxia or central cyanosis, and lethargy. And that lethargy can be from, excessive orca breathing for a prolonged period of time. They're getting tired. It can be from dehydration. It can be from hypercapnia. So it can be multifactorial. Common examples of this include bronchiolitis, as our case earlier, croup with stridor at rest, or asthma with an acute exacerbation. Your immediate action plan is airway, arrange transfer, and provide life-saving treatments as you're able. For respiratory failure in the office setting, I want to empower everyone that there's a lot you can do with limited or no resources. So don't feel like, okay, if you can't intubate the patient or you can't place an LMA, then you can't do anything to help the patient. And that's not true. Positioning is very important, especially in a pediatric airway. You could see in that video, patients are crumpled over like this. They don't have a lot of tone in their neck. So let's get them out of the car seat. That's a big one in office settings, and in the ER also. You have this patient that's like, and they're in their car seat. So getting them out of their car seat. You can put them in a treatment bed with a shoulder roll to help optimize the alignment of their airway, or have them sit up with the parents in their lap with a good head tilt and chin lift. Like even having the parents help hold, that might be the most comfortable for the patient. And then suctioning. So this is part of your acute airway management because you're clearing a mechanical obstruction. that is, all of those nasal oral secretions act as a functional obstruction for these patients, especially the little ones. And so that is a big piece of it. So when we talked about our essential equipment, currently a lot of the PCP clinics are stocked with the blue nasal and oral bulb suction. And that would be all you might need for a patient in this age group. If it's a 16-year-old that's foaming from a seizure or an ingestion, then maybe that won't cut it. So, in the emergency setting, we're big fans of a rigid suction because you can use it not only like something like a Yeager device, because you can use it not only for a respiratory patient in the nose, in the mouth, but also for your acutely altered patient, your ingestion seizure patient. You can test the airway gag and see if they have an intact airway. So there's a lot of utility in a rigid suction device, but you'll have to do a needs assessment and figure out if that would work for your setting. And then meds. For bronchiolitis, of course, we know that there's not a lot of utility. It's all supportive care, but for asthmatic or the Cooper, albuterol, racemic epinephrine, and dexamethasone are all on formulary. And then supplemental oxygen. So even if your patient is 91% on room air, but they're breathing 80 times a minute and they're using all their accessory muscle use, put them on oxygen anyways. Maybe it'll help them like reduce their work of breathing, make them a little bit more comfortable, reduce their effort while you're waiting transport. And if you're just doing a nasal cannula or just a non-rebreather, that is perfectly okay to transport them by BLS with that. And then in terms of thinking about your process, you keep the patient in the room or move them to a treatment room. And a lot of that will come down to what resources you need and whether those resources are mobile or not. And then knowing where all of this is. Some of this stuff, so oxygen, I think suction and oxygen can be pretty bulky. So knowing how all of that works and gaming it out with a mock scenario can really help reduce stress of this happening in real time. And then disposition. Any hypoxic patient or any patient receiving active treatment needs to go by ambulance. Is there a role for urgent care disposition? Probably in an acute patient that needs ongoing treatment, maybe not. But maybe you did some suctioning, you reassess them, they look like a peach now, they tolerate PO in the office. Maybe there is a role, and that it can be an excellent avenue for connecting with connected care, like, hey, this kid looked like crap when they came in. These are the things I did. Now they look pretty good. What do you recommend? We're happy to have that conversation. I included the Mr. SOPA acronym here for you. This is specifically for NRP, but you'll note what I want to call your attention to is most of these interventions have nothing to do with an advanced airway, like adjusting like a non-rebreather mask or a back valve mask, repositioning the head, suctioning, opening the mouth, and doing a jaw lift. These are all things that you can also do in the clinic without any additional equipment. So it's not until the P that you get to anything invasive. So I think that's a really good thing to keep in mind. All right, case 2, and now no more links or anything. Case 2 is a 3-year-old male who presents to the clinic for 3 days of fever, vomiting, and URI. The patient has a past medical history of epilepsy. They are compliant with their home meds, including Keppra, but mother notes that he has had frequent vomiting after meds and meals. While obtaining vital signs, the MA calls you over to say that the patient is having a seizure. You have some partial vital signs here, and you note that the patient is having active generalized tonic-clonic movements, foaming at the mouth, and has some perioral cyanosis. So what is your next best step in management? You're going to notice a theme. Call 911 is one of the options for every case. Anyone surprised by the answer choices? Good, yay. I love when there's, as Zeb would say, a smattering. All right, so we have The most popular answer is C, giving supplemental oxygen by non-rebreather, B, asking the mother to give the home rescue clonazepam, and A, calling 911 and transferring to the ED. So again, you have a case where multiple things would hopefully happen simultaneously. So now remember that this patient was not hypoxic yet, but they had some perioral cyanosis, so getting there. They might also have had some disordered respiratory effort, which is common in an acute seizure. So absolutely, this is all great. Hopefully all of these things happen at the same time or very close to it. Seizure management. And the case, so EMS has IM and IV benzodiazepines. So say this is a patient who is having like a complex febrile seizure, or this is the first time seizure, or they had an ingestion and now they're seizing. All, like if there's not access to benzodiazepines, and often Versed controlled substances are hard to stock in an outpatient clinic setting just willy-nilly. So I'm not expecting IM Versed to be part of your clinic formulary, and that's totally fine. But it is part of every EMS rig. So they have IM and IV benzodiazepines. So calling EMS is a high priority. But while that's occurring, your ABCs are still very important. So that positioning, supplemental oxygen, suctioning, especially, they're foaming, things like that. A caveat for seizure patients in particular is ensuring the patient's safety. This might be a 3-month-old, it might be a 13-year-old. So making sure that if they're on a bed, that they're not going to roll over, fall off, hit their head, things like that. And then now you have 2 problems. So ensuring their safety, and then suctioning their airway for airway clearance. And one thing that's really like kind of unique in the seizure population, a lot of the family members have a high degree of comfort with administering medications. There are, of course, there's going to be medical legal issues. I'm not going to recommend that you just give a home medication yourself without verifying it and knowing and things like that. But often the parents in the room of a known seizure patient who seized at home, they've had to give their clonazepam wafer or their intranasal Versed or their rectal diastat. They have done that more often and with more comfort with their child than your staff may have not had to do that ever or anytime recently. So that is totally okay. It's good practice to recommend that parents bring their meds to the office visit anyways, because then you could review their med rec, make sure that their medications are up to date. But then you also have it in the room if they seize. So this is just great practice. Disposition. This is from that MedEd portal. Any patient who has any concern that they're neurologically not intact, and it could just be that their seizure stopped, but you gave them a benzodiazepine from their clonazepam wafer, the seizure stopped, and now they're sleepy, or they're postictal from their seizure. If they're not back to baseline, if there's any cardiorespiratory abnormalities, any concern for need for ongoing workup, including infection workup, head imaging, anything like that, please send them to us. And often, even if it's a low risk case, like this is simple febrile seizure, but if it's a first time simple febrile seizure and you know exactly what it is, everybody knows exactly what it is, the patient looks fine, that mom or dad, this is like the scariest thing that's ever happened to them. And most of simple febrile seizure management in the ER is education, reassurance, observation. These are things that take time. So it can be very difficult to do in a busy clinic setting if you've got 30 patients behind that one that just needs to sit there and do all of that education and observation can be difficult. So absolutely, if there's concerns, then we are happy to see them. But if it's a simple febrile seizure patient that has had that, or their sibling had it, mom had it when they were growing up, everyone's fine, no one's freaking out, the patient's back to baseline and vitally normal, they have an ear infection, you're going to treat that with some amoxicillin. Feel empowered that you can do that and they don't need to come to the ER. If there's any complexity, focal neurologic findings, or anything like that, they might need to have outpatient referral, and then have a plan for them to come back and see you in the clinic. Okay, we've only got 10 more minutes. I can do one more case and then we can do questions. We can maybe the last one. This is Jimmy. He's an 18-month-old male. He was seen in your office for a left ear. He had recently been treated with Augmentin, but now has a recurrence. Mom's having trouble giving him oral meds, so you decide to give him IM Rocephin. 5 minutes later, the nurse calls you to tell you that Jimmy isn't looking so good. He has some moderate respiratory distress. He's tachypnic. He's 91% on room air. He's tachycardic. Blood pressure is okay. His weight is 12 kilograms, and he has diffuse wheezing with an urticarial rash. Your next best step in management. Time will go. Good. Awesome. Yay. Awesome. Great. So the most popular answer was B, which is administer your 0.15 EpiPen through an auto injector in the thigh. And of course, you're also going to call 911. So that's great. A few of you selected the 0.3. So let's talk about dosing and all of that. So it sounds like everybody recognized appropriately that this is a patient in acute anaphylaxis. Here's some clinical criteria for you to reference for anaphylaxis, but long story short, we think of this as, two body systems with the setting of an allergen exposure. So rash plus wheezing or rash plus hypotension or vomiting, things like that with a clinical history. Here's some additional signs and symptoms for you. The big thing to remember here is that the first line of treatment is IM epinephrine. And we always recommend the auto injector and in the lower extremity, in the thigh. This has the auto injector, for one thing, much easier for staff use and a much lower incidence of medication error or adverse side effects when you do it through the auto injector rather than trying to have code doses of Epi that you then draw up. And there's a lot of risk associated with that if it's not something that you're using. Adjunct medications such as albuterol, dexamethasone, Benadryl. Number one, these are kind of falling by the wayside in terms of evidence-based practices. It's like epi, and sometimes that's all you need. And if you ask an allergist or an immunologist, they'll say that's all you need. So don't feel like you need to do these adjuncts. Give the epi, get them somewhere else. You want to monitor their airway and blood pressure closely while awaiting your emergency services. So now you've given epi, you called 911, you're waiting, you're going to keep monitoring vital signs. If you have time to give them those adjuncts, great. If you don't, no worries. Or if their symptoms completely resolved, then don't feel like you have to, and especially if they're vomiting or not tolerating oral intake. Newer literature is favoring a shorter observation period, but currently the standard thinking is the observing for biphasic or recurrent anaphylaxis with a 4-hour observation. So we're happy to take these patients. We know that you can't just sit on them during the clinic day. And this is a lot. So this last case is an infection case. So it's also, there's simulations available for it, but my slides will be also. But just a quick word on sepsis and infection. Timely antibiotics and fluid resuscitation are the only modifiable risks for outcomes. So don't delay transfer. Try and get an IV or do an extensive workup. We know you don't have blood draw stations commonly in clinics, so maintaining a high index of suspicion is important. This is another visual key that you can blow up and print out that has reference vital signs, because as we know, those vital signs change by age, and that can be a hard thing to remember in the moment when you're having an acute emergency. Takeaways here before we end and open up for questions. The receiving facility is not expecting you to definitively care for emergencies. We are not sitting there thinking like, why didn't you do the X, Y, Z? Why didn't you definitively care for these patients? We don't expect any of that. When we have resuscitations or traumas, there's like minimum 10 people that come into the room. So we're very resourced, we're very equipped. So trying to execute that in a clinic setting is not our expectation. But it is important to optimize your space and accessibility for resources and have regular process implementation and practice. And then again, the plug for Connected Care, we're here if you need us. And now I will open it up for questions. What is that?
It's fine.
Oh. You don't want to just look at pictures of my cutie kid? I can take any questions you have. If not, I'll be here after.
Okay, here's one on the Q&A. My office stopped stocking EpiPens, saying to call 911 instead.
That I think that is an approach. Is your office response time less than 10 minutes? That probably will work out. I think if you're in a location that has a longer response time, that can be used as a kind of a justification for restocking it. I know that there have been concerns about cost and things like that, but even with the higher costs, I think safety wise, I would still preference the auto injector over having vials. But I think, yes, calling EMS, they also have Epi available in the rig, so you absolutely could use that approach. But if it's possible, I think the evidence for early administration of epinephrine is there, especially if you have a delayed response time for higher care.
Okay, here's another one. How does the management change on PCH campuses when there is an ED nearby?
Actually, we have the PCP clinics throughout the valley do have like one standard SOP for emergencies. In terms of our ambulatory clinic that's right here, you know, the general pediatric clinic, they can still call 911. The fire department is very close by, but also we are available and can respond to zip code blue is possible. But other than that, the management would be the same to call for emergency services while optimizing care.
I saw that you had information on how often clinics experience emergency. Is there anything out there about how prepared on average like clinics are?
Yeah, that's a great question. So there's a disconnect in the literature. Most respondents to surveys will say that they don't feel like completely prepared for every scenario, but often there's also at the same time a feeling of over preparedness compared to what actually is seen. So when we talk about emergency preparedness, there is actual quantifiable and objective pieces to that, and we do that with outside community EDs, right? Like, do you have pediatric masks for back valve masks? Do you have pediatric size ET tubes? Things. So there are objective pieces to emergency preparedness, and those are significantly lower than the perception of what you're prepared to handle in the clinic, and that bears out in experience, right? Like, we might be sitting here thinking like, I got this, I know anaphylaxis, like no problem. But then when it actually happens in a rare instance in a setting that you're not used to, then things kind of go out the window. So there is a disconnect there. But overall, most practices responding to survey studies felt that they could definitely use more prepared preparation, which we all could.
Karen, I was just going to make a point for like those of us that are taking MOCA peds or studying for boards. When you have answers that are all things that you would do,
Yes.
the correct answer is always you do something before you turf it to somebody else, right? So you administer oxygen before you call 911 to have someone else do something, or you give oxygen before you have mom give the clonazepam wafer. So that's almost always going to be your answer choice when you have things that are lined up, they're all things that I'm going to do all four of these. The best choice is the one that you do something.
And then especially when that action item pertains to airway or life-saving interventions, the test will always preference. If there's like one thing you can do that could be potentially life-saving, we'll always. Thank you. Any other questions? Nothing else in the
I
chat?
think we're right at 8:30.
All right. Can I ask more?